Good afternoon. I'm Dr. Majumdar. I'm a pediatric endocrinologist. I'm also the medical director of Children's Healthy Way of Buffalo. It's a multidisciplinary program to help families, especially youth, manage their weight. And I want to thank Kaleida Health for this opportunity to present a topic which is very close to my heart. Youth are struggling with obesity, and we are failing in the management. It's time to manage it differently. And I want to take you through the journey and how we've achieved in Healthy Way of Buffalo. The way we think of obesity is a balance between energy intake and the energy output. This is a very simplified model. And the way we think about it is whenever there's abundance of food or there's lack of exercise, or in this case, someone thinks that they're exercising but using an escalator to go to their fitness center, the energy balance tips towards excess energy and we get obese. However, based on this model, we've been telling everyone that we need to diet to decrease how much we're eating and increase exercise so that we maintain healthy weight. However, this strategy is clearly not working. It's not just affecting obese individuals in the United States. Obesity is now affecting youth all over the world. In the United States, about 17% of youth are obese. And in Western New York, the rates are even higher, about 17.3%. Why are we failing in this process? Because all this time we've been focused on just helping patients lose weight using diets without even thinking why the individual is gaining weight. And to understand that, we have to go back in time to remember where we came from. We've evolved over millions of years. We've developed a system of hormones which has helped us in times of famine. We've developed hormones like leptin and ghrelin, which prevents us from withering out when there's a famine. But we've never developed a very robust system to defend us against excessive weight gain. And whenever the environment changed, our body developed storing energy. And what are these changes that are affecting us, which leads to obesity? To understand, we should look at the main crux of what leads us to eat, which is hunger. It's very simple to understand that when we are hungry, we want to eat. And that comes because we have a robust system with checks and balances which tells us when we should be eating. One of them is the hormone called ghrelin, which is there, comes from our stomach. We think about the growl, growl, growl hormone. That's how we remember it's something called ghrelin. While there's one hormone which helps us become hungry, there are multiple, on the other hand, which helps us control or bring our hunger down, especially when we have eaten. And this check and balance system has been there for millions of years. However, in the current environment, this balance may have been disrupted. We do know that there can be genetic variations which affect this balance, and we at Children's Healthy Way of Buffalo, we test for these genetic mutations. But luckily, these are not the common thing which affects our hunger. Probably what's more important is a change in environment which has occurred over the last 50 to 100 years. There are things which have changed which have affected our eating habits, our sleep habits, and the combination has led to what we call disruption of the circadian rhythm. In simple terms, the day-night rhythm. Let's think about some of those changes. before we go into management of weight. The common change that has occurred over the last 50 to 100 years is we've probably stopped cooking as much as home. When we used to cook at home, we used to use probably a variety of real foods, but once that's gone down, we've gone towards more and more of ultra-processed food, aka fake food. These food are supposed to give you energy, they're supposed to make you feel full, but they probably confuse your body and leads to overeating. And this was very well studied and in fact published a few years back, that when you're eating just processed food, your body needs to eat much more, about 500 calories more, just to stay satisfied as against real food. But is that the only thing that happened? Probably not. Probably one of the big things that happened around the turn of the century is these two things. We got electricity and we got a bulb. And what happened after that? We thought we can do anything, any time of day or night. We can stay up at night and work and eat, and life changed. But our genes don't change. We've evolved over 1,000,000 years. How can that change over a matter of 50 years? And this was actually tested about 2 years back in primates, in baboons who are very similar to humans, and it was clearly shown that our genes do go to sleep at night. Our forefathers knew that. They have been telling us that for years. But we actually showed that through genetic testing, that during the morning and the pre-dawn period and the pre-dusk period, our genes are very active, and as the dark sets in, they go to sleep. So if we are up at night, we are putting in energy when our body is going to sleep. That in one way is a sure shot way of gaining weight. The other thing it will affect you is if you're up at night and you're doing activities which affect your sleep, it has additional effect which will make you gain weight. One of the important things is that it affects those hunger centers, those hunger hormones that I was talking about. Just staying up at night, your body will release chemicals that will make you hungry the next day. And therefore, it's very well known that their eating habits, which are associated with excessive weight gain, are quite often associated with eating at night, like night eating disorders, binge eating, they typically occur at night, or emotional eating, boredom eating, mindless eating, typically occurs at night. Now let's look at our adolescent population that I focus on. The hallmark of their eating habits is irregular eating. The common thing you hear is, I feel sick when I eat breakfast, or the school lunch is so nasty, I do not want to eat the school lunch. Well, there may be some truth to it, but let's put it in a timeline. A young adolescent does not eat breakfast and lunch, probably eats the first meal around 3:30, and then stays up till midnight or sometimes later. And at that point is feeling really hungry because of they have skipped the meals during the morning, and all they have is this processed food to help them stay full. So they eat till about midnight, and then next morning again around 3 in the afternoon. So there's a starvation period going on 15 to 18 hours at the time when your body's genes are active, and you're putting all the calories when your genes are going to sleep. In addition, they're sleep deprived, and as I pointed out earlier, when you're sleep deprived, you release chemicals, you get hungrier. Therefore, the current focus of treatment, which is focused only on diet without touching any of these topics that I discussed earlier, will probably not lead to a successful long-term weight management. Worst of all, the current strategy focuses on blaming and shaming the patient and the parent, with predominant focus only on weight loss, rather than focusing on the underlying cause, which is the uncontrolled appetite. Because if we do not help control the hunger, the individual gets irritable and worse off will start sneaking food. And if we focus only on weight loss rather than hunger control, our hunger hormones, ghrelin, the growl hormone, actually goes up, and the hormones which help you control your hunger goes down, which is so sad. Another important problem that we typically face is we're focused only on weight. Now we know that kids are growing, and therefore if we focus only on weight to measure the outcome of their success, if we call it, then probably we're not doing them justice. Sometimes we adjust their weight for a height and we calculate the BMI or the ZBMI, which is better tool, but probably not good enough, because you can have a tall person who weighs a lot, but he or she is all muscular, and therefore their BMI will be elevated. So our approach towards outcome measurement also needs an adjustment. Worst of all, there are multiple myths out there, and a lot of social media, including us providers, are to blame a lot of times. We typically think of individuals with obesity as those who lack self-control or willpower, and worst of all, lazy. You've heard all that. You need a new approach towards your weight management, and that's typically what we do at Children's Healthy Way of Buffalo. We follow the rules of nature, all the things that we talked about. You need a team on your side who's not going to judge you, who's going to celebrate everything that you do. Even the fact that you showed up in the clinic, you overcame multiple challenges to come to the clinic, and we will celebrate even that. And any success that you have or lack of, that's also to be celebrated. We will not focus on your weight, as I was trying to allude earlier, because we have tools, the right tools. We measure your body composition. If you're exercising and growing tall or building up muscles, your weight will go up, and we can tell you that from this body composition machine, which will check your muscle mass, and it'll tell you that you're building muscle, which is a great thing. We have a team of providers which will focus on your child's care, because you do need more than just a physician to help you out. We have psychologists, physical therapists, dietitians, and surgeons to help us in the process. And if I haven't made it enough, if I haven't made myself clear enough, we will not talk about dieting, because dieting is going to make you hungry. A person who's already struggling with hunger, we have to make things easier for them. So we will focus on the natural ways with a simplified, structured meal plan, using real foods available at home, none of the fancy, expensive diets. Something that you can continue not just for 2 or 3 months, but probably a lifetime. And obviously, with a holistic care model, we want to help the family as a whole. So everyone in the family, we want them to participate along with the child. We'll focus on sleep, because as I was talking earlier, it's one of the important parts towards hunger management, and therefore we should be focusing on that. And if you're doing that right, this is the kind of results you'll get. These are our own data, which was published last year. The children who were referred to us prior to attending Children's Healthy Way of Buffalo, their weight and the ZBMI, the adjusted weight for the height, was going up rapidly despite their efforts prior to presentation in the clinic. And even after one visit, we reversed that pattern, and the ZBMIs continued to go down, as a continued follow-up in our clinic over the next few visits. But the root truth about medical management is that it is very challenging. It needs time. We need multiple providers to help you out. You may have multiple barriers that is preventing you to be able to implement change. But we are there to help you. There are no easy, simple ways to make the weight, to improve your weight. And we need an individualized care. Medicines are available, but while they're very effective, they're mainly for adults. And unfortunately, in New York State, majority of them are not supported by our insurance companies at this point of time. However, we have other opportunities, especially those with extreme weight who are struggling with other medical conditions. We can take you to the next level where we can take you to a surgeon who will help you with metabolic surgery. At this point, I will call Dr. Harmon to take over the platform. Thank you.
Thank you, Dr. Majumdar. So my name is Dr. Mac Harmon. I'm the surgeon on the Children's Healthy Way of Buffalo team, and I have been participating in adolescent bariatric surgery since 2004, and I'm happy to share a little information with you around what early on people thought of as this. Weight loss surgery in kids, are you crazy? Well, it turns out that we've learned a lot over the past 15 years or so about the possibility of certain select teenagers being candidates for what we call metabolic and bariatric surgery or weight loss surgery. So first, we'll discuss a little bit about who might be considered a candidate for bariatric surgery in teenagers. And the recommendations that we have currently would be for a teenager to have a body mass index of greater than 35. That's oftentimes 75 to 100 pounds overweight, and complications that go along with obesity, such as diabetes and sleep apnea, severe headaches, and liver disease that are associated with severe obesity. Another group of patients who might be considered are those with a slightly higher body mass index of 40 and other obesity-related conditions that are not quite as severe as the ones I mentioned, that include things like bad heartburn and severe psychosocial distress, joint pain because of the weight, abnormal blood lipids, hypertension. These are other obesity-related conditions that might have a teenager be a candidate for weight loss surgery. So for us at the Children's Healthy Way of Buffalo program, we mandate that any teenager who might be a candidate actively participate in our program for at least 6 months to get to know the multidisciplinary team and for us to get to know you and your family. They have to have the ability to understand what we're talking about, because bariatric surgery in teenagers is a big deal, not a little deal. The ideal candidate has strong family support and friend support, I must add, a real commitment to the process because we would have to follow them after their surgery for a long time. And so far, we've not offered the operation to kids less than 12 or 13 because we'd like them to be fairly mature from a physical point of view before considering this treatment. Where should your adolescent perhaps have bariatric surgery? Well, I feel very strongly that it needs to be within a multidisciplinary team program. So you just don't show up at your surgeon and say, hey, I'd like weight loss surgery. You need to be part of a program that includes the specialists that are listed here, including folks that Dr. Majumdar mentioned, like our psychologist and psychiatrist and nutritionist, nurses. And we also have a group of doctors who specialize in the care of obesity, such as gastroenterologists and pulmonary doctors, orthopedic surgeons, who also participate in the care of these complex patients. Well, what's on the menu for possible operations for weight loss surgery in teenagers? Early on, we thought that this belt idea around the stomach would be a good one, called adjustable gastric banding. And you basically would put this belt around the upper stomach and you could then tighten or loosen it as needed. However, this turns out to have more complications long term than we really would like to see. And in fact, the FDA has never approved it for patients less than 18. So we've really dropped this one on our menu. The second operation, which has been around a long time, is called a gastric bypass. And you can see from the picture that the majority of the stomach is disconnected from the upper stomach. And so food essentially goes into a small pouch about the size of an egg. So therefore you can only eat so much. And then the food and the calories basically bypass much of the intestine and go downstream through the intestine so that you can't absorb as many calories. Many patients who have this operation, which has been around since the 1970s really, lose about 30 to 40% of their weight. But this is a big operation and has quite a few complications on the list. And so in the last 10 years or so, many surgeons have shifted to a sleeve gastrectomy operation, which is removing about 80% of the stomach. So again, you can tell from the diagram that food would go down your swallowing tube or your esophagus and go directly through your stomach quickly and into the small intestine before you have a chance to digest a lot of food. And you can only eat so much food because the stomach is very small. Dr. Majumdar mentioned ghrelin, which is the hormone that tells us to eat. And you can see that after this operation, we take out much of the stomach where the ghrelin is secreted, and therefore your appetite urge goes down, which also helps with the weight loss. I'm now just going to share some results with you so you have an idea of what we're talking about for bariatric surgery. So the TEAM lab study is a group of 5 children's hospitals which have collected data and followed children out to 5 and now 10 years. And you can see here in this graph where we're looking at weight loss, comparing the sleeve gastrectomy with the bypass. Here's our baseline weight, and then in the first year, the patient drops about 30% of their weight in that 1 year. And then we're happy to see that as we follow these patients out to 2 years and 3 years, they don't have a lot of weight regain, and they keep the weight off so that at 3 years and 5 years, you still have lost 30 to 25% of your weight. So that's pretty good results, and we're happy to see that in our teenagers. This is another example of the effect of weight loss surgery on high blood lipids or fats. So you can see that almost 80% of the patients, 70% of the patients have high blood lipid levels at the start of their treatment. And again, you can see that by 1 year, 2 years, and 3 years, that the blood lipids come back down to normal or close to normal and stay there, which is another good finding for long-term health and not just about weight loss, as Dr. Majumdar mentioned. This is a recent study that compared teenagers who had weight loss surgery to adults. So the blue line is the teenagers and the yellow line is the adult population. And you can see that over time, if we look at weight loss, the teenagers have equal weight loss to the adults, again in the 30% range, extending out to 5 years. This again is looking at resolution of type 2 diabetes in teenagers versus adults who have the surgery. And you can see that even at 1 year, 70% of both teens and adults have remission of their diabetes, which is great. But what we're very happy to see in the teenagers is that as you get out to year 4 and 5, the teenagers continue to have remission of their diabetes all the way up to now 85% of the patients, where over time the adults tend to fall down a little bit, still have good results, but the teenagers seem to even perhaps do better than the adults in terms of correction of their diabetes. This is another example of looking at remission of hypertension in teenagers and adults. And you can see again that the teenagers in blue have a very good remission of their hypertension that seems to maintain itself out to 5 years after surgery, perhaps better than the adults. This is an example of what we call health-related quality of life. So this is the patient's own perception of their quality of life. The blue line shows a very diminished perception of their quality of life. The green line shows normals, and the pink line shows what a teenager who's 1 year following adolescent bariatric surgery feels about the quality of their life. And you can see that they feel better about their quality of life than even normal weight people of their same age. So just some quick examples. Here's a young girl who was 16, had a body mass index of 46. She had complications of obesity, including hypertension and sleep apnea. Her mom had had weight loss surgery. That's a gastric bypass. And here she is 2 years following surgery. I'm sorry you can't see her smiling face, but her BMI has dropped to 27 from 46 at 2 years, and she is very happy with her life. Here's another young man who's 15, a BMI of 60. He had complications of the obesity as well. And 1 year following his surgery, his BMI has dropped to 40, which is the 30% we've talked about. And again, he feels, though he still has a ways to go, he is in much better shape than he was before. A young lady of 16, BMI of 48. She had diabetes and hypertension and sleep apnea, almost every complication you could have. And here, in simply 6 months, she is now off her insulin, off her CPAP for her sleep apnea, and off her hypertensive medication. This young woman, a 17-year-old, BMI of 47, depression, had high blood lipids, and 2 years later, a nursing student wanting to go and help people manage their weight. This young man, a 16-year-old, a BMI of 60, he wanted weight loss surgery so he could join the Marines. 2 years after his operation, his BMI is down to 30. The Marines wouldn't let him join, but he's a police officer now. This young man, BMI of 55, was in our program. He dropped out of the program and came back a year later with his BMI having gone up to 62. This young man, a 17-year-old, a BMI 48, he wanted to play high school football. He had gotten too big to play football. And here he is 4 years later, BMI down to 25, and he's a happy college student. This young man, 15-year-old, weighed 146 kilograms, had liver problems, and 1 year post-op, here he is here in Buffalo with his BMI down to normal, and he gets the lead in the high school musicals to sing and dance on stage. So that's a quick review of bariatric surgery in teenagers, and would be happy to take any questions you might have, and I'll turn it back over to Dr. Majumdar to finish up.
Thank you for this opportunity to present this topic today, and I am right now seeing quite a few questions up here. So number one, let me take this off a little bit. How can you tell the difference between baby fat and a concern for obesity? That's actually a very good question, and quite often we think about weight in the early years as being baby fat, which will go away. And if we go back to one of the slides long time back, I showed something called as the body mass index. And one of them, while it's not perfect, it can tell you some differences between the two. And let me go back here and explain a little bit. Most individuals in the first few years of their life, their weight, even adjusted for their height, goes down before it goes up. And this is natural. When this doesn't happen, or you go up like this, chances are that this is not just baby fat. This is something more than usual. While if you're tall and you have a lot of muscles, this may come up inaccurate, but with a good physical exam, and especially with the machine that we have, we can tell the difference. On to the next question. How can I encourage my child to eat more fruits and vegetables? That's a very, very good question. And I understand that children are finicky and they do not like to eat too many fruits and vegetables. And the standard way we encourage kids is talk to them about real food and the processed food. Introduce one food or one fruit and vegetable along with what they eat. For example, in my home, the rule is If you're going to eat one fake food, you have to have a real food with it. So that's simple. They are allowed to eat the things that they like, but they are adding on something on top of that. It works, but it does need multiple attempts. Third question. I try to limit the amount of food my son consumes, but he's always complaining that he's hungry. What do I do? This is actually the crux of what I was talking about. To lose weight, traditionally, we've talked about just restricting what the individual is eating. But probably that's not the most effective way for the help our youth. As I was alluding earlier, hunger is very intrinsic. Unless we address the hunger with the right approach, we will be losing the battle against obesity. In fact, if we just tell someone to stop eating, they will feel hungry. They will find ways of bypassing you, sneaking behind you to overcome their intrinsic desire to eat. So instead of fighting, we should find strategies of helping our child's hunger. Then at Children's Healthy Way of Buffalo, that's what we focus on. It's the hunger control. In fact, we should probably change the name of our clinic and make it a hunger control clinic. That's our whole model, is how to help our individuals control their hunger better. We have a team which helps, including, in addition to me, the dietitian and the psychologist who helps us. Next question. You mentioned that you follow the patient in your program after surgery. How does the program change from pre-surgery? Probably I can go ahead? Okay. So we have the same team of providers. I'm an endocrinologist, but I'm also a medical person trained in bariatric medicine. I'm a pediatric bariatrician. The same team, the same dietitian, the same doctor, the same exercise person, the psychologist will continue to follow the patients before and after surgery, so that the family and the patient does not feel any change from earlier. And that's the key aspect of continuity of care. We develop trust with our families, and we continue that on a long-term basis. Next question. What is the recovery like post-surgery?
2 days.
2 days in the hospital. Dr. Harmon is prompting me from the back. And what exactly is done during the surgery? This is beyond me.
We have time
for you if you want.
Okay, yeah, let me answer the other question first. What do you think of fruit and veggie punches for young kids? Okay, very good question. So the question would be, are fruit juices, fruit punches the same as fruit? The simple answer to that is they're not the same. In fact, they're as far away from the other as possible. One is fruits are real. They're real food. Fruit juices and fruit punches quite often come from factories, so I call them factory food. World Health Organization calls them processed food or ultra-processed food. Some people call them fake food. And that's the key difference that we have to make to our kids. It's okay to eat fruit, but fruit juices, fruit punches is probably not the same. And they're not equivalent at all. I'll call Dr. Harmon for a surgery-related question.
Well, thank you for the question. So most of our teenagers come in on the day of surgery. They have an operation that usually takes a couple of hours, and we do it through minimally invasive surgery techniques. So we do a laparoscopic operation, so there are 4 or 5 small stab holes in the abdomen. We have to make one of those holes a little bit bigger to get out that stomach that we take out that I mentioned earlier. And then patients are in the hospital typically 2 days after surgery to recover, make sure they don't have any complications. And then when they go home, it still takes a couple of weeks to get all the way back to full speed. It's an adjustment. It's a big operation, but patients are able to walk around, do what they want to do. They have to be on a certain diet, and we see them back frequently in the clinic, in the office, by that same team of people. And I say to them that we want to follow you for life. So as long as you're willing to come back to see us, even at Christmas break or holidays or summertime, we'd like to keep track of you, and the patients who do that have better results. And then, again, what is done during surgery, specifically if we do the sleeve gastrectomy, is to remove that 80% of the stomach. And then if we do the gastric bypass, that's consistent with the drawing that I showed earlier about rerouting the intestine to some degree. So thank you very much for your attention. We really appreciate you participating. If you have other questions about our program, we'd really love you to contact us. We've seen hundreds and hundreds and hundreds of kids from age 2 to 19 in the program. So it's a broad program, and we'd love to help take care of your kids and teenagers if that would be helpful.